welcome back. We are going to get a little deeper into the topic of nursing and the law today. We're going to start out by kind of picking up where we left off on last time. We were talking about the Nurse Practice Act and the scope of practice for an LPN. And a lot of people ask, well, what is the difference between the scope of practice for an LPN versus an RN? Okay, so I think that this particular table here really kind of does give a nice a differentiation between the two. So let's take a closer look. So in terms of assessment, we know that RNs are required to do the initial assessment on the patient. So that means when the patient first comes in for admission or post-operatively, that initial assessment by the RN or assessment of an unstable client, all right, or an unstable patient. Whereas an LPN is more along the scope of monitoring the RN's findings, okay? So the RN has established the initial baseline admission information and assessment, and the LPN monitors the findings of the RN, can gather additional information and add that to the database, and then also assess the patient as long as they are stable. So being able to do focused assessments or subsequent assessments after the initial assessment is well within the scope of practice of the LPN. When we're talking about nursing interventions, you will find that during this program, you will be learning almost every single skill that is performed by a nurse. And that includes registered nurses and LPNs. We teach you how to perform just about every nursing skill there is to perform. However, there are a couple of exceptions. And so RNs are only allowed to administer IV push medications, okay? That is only in the scope of an RN's practice. RNs are only allowed to administer blood products. So if a patient requires a blood transfusion, that must be done by a registered nurse. The same for total parenteral nutrition and medications that require titration and continuous monitoring. So an example of that might be if there's a patient in the hospital who's on a heparin drip, that is a medication that requires titration and continuous monitoring. And that is only something that is within the scope of an RN's practice. Accessing implanted devices, so ports, for example, that is something that is more reserved for the practice of a registered nurse. Registered nurses interpret and analyze data that require more complex critical thinking. And an example of this would be really the development of a plan of care for a patient. So this would be something that an RN would do because it requires more clinical judgment and complex decision making. However, on the opposite side of that, in terms of interventions, LPNs can provide basic patient care, right? You are going to learn how to insert Foley catheters. You are going to learn how to be able to assess your patients, changing dressings, doing all kinds of skills, giving injections to patients, giving medications to patients, giving medications in a PEG tube or in an NG tube. These are all within the scope of practice of an LPN. reporting the client's status to the RN. So basically the LPN kind of works under the direction of the registered nurse. You can care for stable clients with predictable outcomes. And so when we have expected findings in the patient, these are chronic patients maybe who have chronic diseases like the ones that we care for in long-term care. They're stable and they have predictable types of nursing needs. But even in that setting, we all know that there is usually an RN on the floor, and we've got an LPN who's kind of working under the direction of that RN. And so then in terms of teaching, again, there's scope. So the initial and discharge teaching is usually done by the registered nurse. And what the LPN is there to do is definitely reinforce the teaching of the registered nurse. And also to provide education to patients that, again, is very standardized within that particular setting. But that initial admission teaching and discharge teaching needs to be done by the registered nurse. So I hope that kind of helps give you a little bit of a picture in the difference in practice between the RN and the LPN. So we're going to talk a little bit today about legal implications in nursing. And so we're going to start with kind of defining what the word negligence means. So negligence is concerned with unintentional fault, okay, unintentional or carelessness that results in injury, all right? So this is considered to be an avoidable accident that should have been anticipated and prevented by taking reasonable precautions, okay? So I'll give you an example. A patient can fall down, right? A patient can fall in the clinical setting. It's an accident that happens. It's never something we ever want to have happen, but it does happen sometimes, okay? And what we want to make sure we're being careful about is understanding our responsibility. And what I mean by that is, did we take all of the necessary precautions to prevent the fall from happening, right? So for example, did we use a gait belt? Do we know that the patient is at high risk for falls? And so we put the patient on high fall risk. We are following the high fall risk standards that are in place to prevent the patient from falling, right? So we're doing everything we can do to avoid an accident. However, we know that patients still fall despite the fact that we really do try everything we can to keep them safe, all right? So we talk about negligence, we're talking about conduct that may stem from, anger, inappropriate behavior. And this is just in general. This isn't necessarily, nursing, not nursing. People can be angry and something really unfortunate can happen as a result of them being angry because they're not thinking straight and they do something stupid and it hurts another individual, right? They didn't intentionally try to hurt that individual, but it was negligence because they were angry and they weren't thinking clearly. Behaving inappropriately, being forgetful, being careless, or just plain old ignorance, right? The person just didn't know any better, all right? That doesn't mean that they were trying to hurt an individual, but their ignorance, their not knowing or not understanding did result in harm, okay? Their carelessness or thoughtlessness or forgetfulness did cause harm to another person, okay? So in terms of nursing, we want to ask some questions. We want to ask questions. We want to ask, is the nurse at fault for the injury to the patient? Okay, and if so, what conduct on the part of the nurse actually contributed to the injury to the patient, right? Could the nurse have prevented this situation from occurring? Could the nurse have prevented it? Should the nurse have anticipated this problem? Okay? Should the nurse have anticipated this problem? So we're going to talk a little bit about that. I'm going to give you some examples here in a little bit. So negligence is really unreasonable risk of harm to the patient. All right? It's ridiculous for a law to require absolute responsibility for all consequences of all acts at all times. Okay? It's ridiculous. Okay? But was there unreasonable risk that harmed this patient? So, what happens in negligence is that the conduct falls below the required standard of conduct in a given situation. Okay? So then you might say, well, how is a reasonable standard established? Okay? So we refer to the individual as a reasonably prudent person. And what prudent means is acting with or showing care and thought for the future. Being prudent, okay, being reasonable, being reasonably prudent is saying, if I don't put the gait belt on this patient and I get them up to walk them, there is a possibility that they may fall, and without the gait belt on, they may have an injury as a result. So I, as the nurse, have to be able to assess risk factors, right? So in other words, assessing a risk for falls, right? How high is this patient's fall risk, okay? And I think about that, and I do something to make sure that that is not happening, that the patient does not fall, okay? So what would a reasonable or prudent nurse do in a similar situation with the same level of experience? And this is important to consider because there is a difference between what would be considered reasonably prudent in a nurse that's been very experienced in this area for many, many years and a nurse who just started on the job last week who make the same mistake, right? So you have a nurse that's made a mistake, who's worked in the clinical setting for many, many years. They have used this particular drug many, many times. They've given it over and over again, right? Compared to a brand new nurse who's giving some of this medication or doing some of these things in a very different time in his or her career, right? They don't have the same level of experience, okay? So this is how a reasonable standard for a reasonably prudent nurse is established, okay? So was it foreseeable? Was the harmful consequence of the nurse's conduct foreseeable? You are not required to have ESP. What is ESP? ESP is ESP, extra sensory perception. It means that you can see the future, right? You cannot see the future. You do not have a crystal ball. There is no magic way, right, for us to actually see the future, okay? You're not required to have ESP. You're a human, okay? We are all human, and we all make mistakes, all right? And so you are not required to have extra sensory perception. What you are required to do is have a reasonable sense to put precautions in place to guard someone against harm. So let's look at an example. The nurse has an order to keep a patient with dementia in restraints so that he does not pull out his IV and the tubes draining his wound, and this patient is currently on bed rest and in restraints. Okay? What are the foreseeable risks? Can you think of any? I can. I want you to take a second just to think to yourself. Okay, they have restraints, they've got an IV line, they've got tubes, they're on bed rest. Well, first of all, this patient is at risk for incontinence. If they cannot get up and use the bathroom because they can't get out of the bed, then they're at risk for becoming incontinent of the urine and their stool, okay? And this is a risk factor for what? I want you to think about it. Someone's laying flat in the bed, they're incontinent of urine and stool, and they are at risk for something. I'm not going to tell you yet. We're just going to keep moving through the risks. Nutrition. Their arms are tied down. They are not able to just grab a cup of water and drink it at will. They're not able to feed themselves, obviously, right? So they're at risk for nutritional deficits, right? They're at risk for becoming dehydrated. They're at risk for a nutritional deficit because of the restraint, okay? So far, we're realizing that we have to be aware that they're going to possibly become incontinent, so we have to make sure that their skin is clean, right? And that they are not laying in urine. We have to make sure that they're eating and drinking because they can't feed themselves or drink on their own. Because if we don't make sure that they're eating and drinking, okay, and that they're not laying in stool or urine, they're going to be at risk for getting a pressure ulcer, right? A reasonably prudent nurse knows that if a patient is in restraints, we have to check them frequently. We have to loosen the restraints and make sure that it's not causing redness. We have to check their skin to make sure they're not getting skin breakdown on their coccyx or on any of the pressure points that they're laying on, right? Because this individual's laying in the bed, can't get up and move around, okay? So these are foreseeable risks that we have to consider, and we have to prevent any of these complications from occurring due to the fact that the patient's in restraints. Here's another huge one, risk for injury. Patients in restraints, if they have dementia and they don't know their limits, they're going to try and get out of the bed, okay? And they can become injured. That is why putting all 4 of the bed rails up is considered a restraint, okay? Look at this individual right here, trying to get out of the bed. It's considered a restraint, all right? All 4 bed rails, and injury is a possible result, okay? So these are important ways of thinking about standards of care, right? Legal requirements for nursing practice that describe a minimum acceptable nursing care. Okay? So these standards reflect the knowledge and skill that's ordinarily possessed by nurses and used by nurses to practice the profession of nursing. Okay? And I would be remiss at this point if I did not mention this very important part of our practice, and that is evidence-based practice. And so what evidence-based practice is it's saying we're taking the best scientific evidence, okay? we're looking at our clinical experience, right? We're talking about the nurse who's been in practice for a long time in the same environment, who knows that practice area, right? So we're talking about the evidence that's coming from research. We're talking about the nurses who've been working at the bedside in that area of specialty and have clinical expertise, and the patient's values, right? Because it always has to come back to patient values, right? So evidence-based practice is the combination of looking at what does science tell us, what does our experience tell us, and what do our patients' needs tell us about how we should be practicing nursing, okay? So, you know, there are some definitions that we need to be aware of when we're talking about standards of care, all right? So that's just a little kind of a way of letting you know kind of one of the ways by which standards of care come to us, right? Evidence-based practice. So every prudent nurse should be familiar with his or her state's Nurse Practice Act and simple terminology related to law, okay? So duty is an expected action that's based on a moral or legal obligation, all right? So nurses have a duty to their patients. And I think what we're going to do is we're going to stop there for today, and then we're going to take an even deeper dive into the legal implications of nursing the next time that we meet. Until then, aloha.